Hey guys, this is Taylor Waters, and I will be doing my presentation on hypertensive emergencies. So, we're all very familiar with the fact that a normal blood pressure is described as 120 over 80 millimeters of mercury. However, when we're talking about emergencies, we're basically describing very acute rises in blood pressure to very high levels. And this is very damaging to organs. And that happens because when you have this rapid rise in pressure, the blood vessels can't accommodate to that, and therefore you have bleeds or damage of delicate structures. So, when we're talking about urgencies and emergencies, they're both defined by the same parameters, by both like a systolic pressure greater than 180 and or a diastolic pressure greater than 120. However, the difference is that an hypertensive emergency has symptoms, which is the evidence of end organ damage, whereas an urgency has no symptoms and no organ damage that occurs. When we're talking about risk factors and causes, it could be more related to essential or primary hypertension, in which there's no other related medical cause to the patient's high blood pressure. And this is mainly like if somebody's just never been treated before, or if they have been treated and they're uncontrolled. And that could be if they're just non-compliant with either their diet or exercise or medications. And then, of course, other things that would put someone at more risk for having high blood pressure is older age, male sex, other cardiovascular or renal diseases. However, there's also secondary causes of hypertension to be considered for a cause of a hypertensive emergency, and those are things like renal artery stenosis, pheochromocytomas, or primary hyperaldosteronism. And when you do have these things occurring, these are mainly going to be patients who are refractory to multiple medications, and a further workup should be considered. But basically, throughout the rest of the presentation, we're just going to talk about all the signs and symptoms and the different ways in which end organ damage can manifest. And in order from most to least common, as far as what those manifestations are, is a stroke, heart failure with pulmonary edema, ACS, aortic dissection, renal failure, and encephalopathy. But as you can tell, most of these manifest as either cardiopulmonary complaints like chest pain, shortness of breath, or palpitations, or for like neurologic deficits like vision problems or headaches. So, to discuss these presentations further, if a patient is having a stroke as the evidence of end organ damage, then you would expect the patient to complain of weakness, numbness, dysphagia, and confusion. However, if they were having an episode of heart failure with pulmonary edema, then you would expect them to complain of shortness of breath, orthopnea, swelling, and then like fatigue and cough. If they were having acute coronary syndrome or a dissection, you would, of course, expect the chief complaint to be chest pain for both. However, with an ACS event, you would expect more MI typical presentation with like nausea, vomiting, palpitations, diaphoresis. And then, of course, with a dissection, you would expect that typical radiating pain to the back that's described as ripping or tearing, with maybe like an episode of syncope present. On physical exam, you're of course going to notice your super elevated blood pressure, but then you'll also maybe notice some of the neurologic deficits, or maybe on auscultation you'll hear the gallop or crackles, and then you could potentially notice diminished pulses. But it's also very important to consider the fundoscopic exam, because if you do it and notice things like papilledema or bleeds, then that could be your evidence of end organ damage in an otherwise asymptomatic patient, and could therefore determine the difference between an urgency and emergency. So when it comes to the diagnostic workup, to meet criteria, all the patient is going to require is a pressure greater than 180 over greater than 120 with end organ damage present. But depending on how that patient is presenting, it's going to require your clinical judgment as a provider to determine which manifestation of end organ damage they're having. So if you think your patient is having a stroke, you would want to order a non-contrast CT of the head. And as depicted to the right over here, you're either going to see an ischemic stroke with like the grayish lesion, or the bright white lesion, which indicates an ischemic stroke. You could further assess with an MRI or a lumbar puncture, and that's when you may see like an elevated opening pressure, xanthochromia, increased red blood cells. If a patient is having heart failure with pulmonary edema, you're going to want to order a chest x-ray, and then of course you're going to see like the cardiomegaly, pleural effusions, which is made evident in this chest x-ray over here by the blended claustophrenic angles, and you'll really just see like a lot of congestion in the lungs. You would want to order an echo to assess whether you're having like any systolic or diastolic dysfunction, and then you could also order a BMP, and it would most likely be elevated. For acute coronary syndrome events, you would want to order both an EKG to see if you're having any ST changes and a cardiac enzyme workup to see if any like your troponins are elevated or not. If you think that your patient is having an aortic dissection, and it's like definitely more of an urgent presentation, you're going to want to start off with the TEE. If you have more time, you could do a CT or MRI, but in either case, you're going to see both the true and the false lumen, and you can notice that in both of the pictures to the right over here as well. If a patient is having renal failure because of their blood pressure, then in a UA, you would expect to see like proteinuria and hematuria, and then in a metabolic panel, you would expect to see a decreased GFR, and then like increased BU and creatinine levels. For a patient who is having encephalopathy, then the diagnostic test of choice is a T2 weighted MRI, and you would see like these very white areas, which are basically just like intensified signal areas, and that's made evident in this picture to the right over here on the bottom. So when you are treating a patient who is having a hypertensive emergency, the main goal is going to be to lower the mean arterial pressure by 20 to 25% in the first 24 hours. This also means that you are going to want your diastolic blood pressure to be lowered by 10 to 15% with a target level of 110 for that diastolic number. You basically want to lower blood pressure at a rate, and you want to like avoid any rapid reduction of blood flow because you still want to make sure that like areas and organs that are used to receiving high flow are still perfused adequately. But as far as medication options that you have, it's basically all going to be different types of antihypertensives, such as beta blockers like labetalol and esmolol, and then you have calcium channel blockers like nicardipine and nifedipine, and then you also have nitrates like nitroglycerin. Basically, research has shown that labetalol is the first line option just because it approaches the target blood pressure most effectively and the most quickly. But all are appropriate, and then any subsequent management should be geared towards the type of end organ damage that is occurring. The main point with these patients is compliance. So it's going to require lots of patient education, whether that be like talking about them being compliant with their medications or whether that be with like diet and exercise. So for their diet, they should be following like a DASH eating plan. They should be doing low salt, avoiding alcohol. And then for exercise, you want to at least recommend like moderate activity, so 30 minutes, 5 days a week for a total of like 150 minutes a week. It's also going to be very important to rule out any secondary causes in a patient that you think may have that occurring. So essentially, the main goal here is going to be to lower the patient's blood pressure and then to just simply prevent any reoccurrences of an emergency in the future by controlling the patient's blood pressure. But that's it. Here's a list of my references. I hope that was helpful. Thanks, guys.